In refractory cases, the first step is to optimize proton pump inhibitor therapy. For some patients, that may mean switching to a different PPI or increasing the dose of a PPI to twice daily. For other patients, compliance may be an issue. In order to be most effective, the PPI should be taken 30 minutes prior to the first meal of the day. It should also be mentioned that gastrin levels may be elevated in patients taking PPIs, so do not automatically fear the presence of a gastrinoma. The addition of histamine 2 receptor blockers to proton pump inhibitors usually does not provide lasting relief. Some patients with nocturnal symptoms may attain additional relief if taken before sleep, however tachyphylaxis usually occurs. In this case, it may be most beneficial if taken only on an as-needed basis. Long-term antacids should be avoided as they only treat symptoms and not the esophagitis. Medical primide therapy, either alone or in combination with other medications, is generally not recommended, except potentially in patients with gastroparesis. Upper endoscopy is indicated in refractory cases, but it usually will not show esophagitis in patients who are taking PPIs. And in actuality, upper endoscopy is unrevealing in many patients with GERD who are not even receiving medical treatment. When there is uncertainty about the diagnosis, such as in patients with isolated wheezing, then an esophageal pH impedance study should be considered prior to initiating therapy or while the patient is off therapy. If the pH impedance test is negative, then gastroesophageal reflux disease is unlikely. If optimal therapy is insufficient and the esophageal pH impedance studies are positive, then anti-reflux surgery should be considered.